Hello, good morning, everyone. My name is Ahmed Sabri. I'm from the regional office of WHO Cairo. Thank you so much for joining our session. We are going to give a bit of focus and update about the region of the Eastern Mediterranean. We have an exciting presentations and panelists to talk about some country work from Sudan and Morocco. We have also a great panel discussion that will talk about hepatitis B in the region and how we can advocate and progress with that in the region. And we're going to give you a progress update about the viral hepatitis situation in the region. I'm going to introduce our director, Dr. Ivan Houghton. He is the director of Universal Health Coverage at the Communicable Disease Department in the Eastern Mediterranean region, to give welcoming remarks for all of you and open the session for us. Over to Dr. Ivan.
Thank you and good morning. It's really my pleasure to join you now virtually. I stopped by, can you hear me okay?
Yes, perfect.
Can you hear me okay? Okay. Very good. So I stopped by the summit on Monday. It was a pleasure to see everybody in person, but I had to be back in Cairo for a meeting with the regional CDC today. So sorry I cannot join you, but I wanted to warmly welcome you to this session. I'm not going to speak for a long time, but I just wanted to attract your attention to the fact that we've actually put together a review of the situation of the Eastern Mediterranean region with respect to viral hepatitis. And Ahmed Sabri has actually signed an article in The Lancet, which is about to come out, that really underlined the heterogeneity of the region. So we really, when we talk about EMR, we're always faced with heterogeneity in socioeconomic status, heterogeneity of situation. These heterogeneity are further reflected in the situation for viral hepatitis. So we've had overall achievers like Egypt that have basically tested and treated almost their entire HCV infected population, but we also have countries, we'll have some example coming up like Morocco, where the prevalence of HCV is much lower in the population, where we will need some more careful approach maybe in looking at what is cost effective. And of course, we have some country that have epidemiological profile similar to what we see in Africa, like Sudan. And I'm very glad that we'll have also this example where hepatitis B is definitely a priority. So from that portfolio, one of the messages that Ahmed has put in his paper, from that portfolio of diversity of situation, we need to get out of the situation where we have some countries that really went very far, like Egypt, and other that didn't get started. And maybe one of the simple first step is actually to integrate testing and treatment as per WHO guideline in a UHC, national UHC package. And that would ultimately is something that could extend towards elimination level. So this is what I usually put at the bottom of my email: think big, start small, begin immediately. Think big is about elimination. Start small is about UHC, PHC package. And begin immediately is at least procurement of these essential commodities in an optimized way by the national program. Thank you so much. Sorry I took so long. Have a great discussion.
Thank you, Ivan, very much for being with us and representing the region physically and also from the background. I see that also Joanna joined. She was having some technical difficulties, so I'm going to pass the chairing of this session to her. Let me introduce her first. Joanna Hermes is our regional advisor for HIV, hepatitis, and STI for the WHO Regional Office for the Eastern Mediterranean. Over to you, Joanna.
Yes, thank you, Ahmed. Good morning, everybody, and thank you, Ivan, for the introductory remarks. Actually, an apology for some confusion about the room that we're supposed to convene in here. So welcome, everybody, and thank you for being here for this meeting. And so this session is about the progress in the region in the region of the Eastern Mediterranean of WHO, as mentioned by Dr. Ivan. I will be co-chairing this session with Dr. Jamal Shiha, a landmark in hepatitis elimination, actually, but he will be co-chairing with me, and he will introduce himself in a minute. So this session will be focusing on reviewing the challenges and the progress at country level. We have different models of countries, and we will be talking about the different challenges and opportunities they have for operating in different levels. We will be hearing about limited resources. We will be hearing about the need to revise targets based on epidemiologic data, and also we will be talking about public-private partnership to move forward in hepatitis elimination. The next part, which will be chaired by Dr. Gamal Shiha, will be talking about prevention of mother-to-child transmission of hepatitis B, and we will be particularly focusing on the main pillar of elimination, which is birth dose vaccination and completion with 3 doses. So without further ado, I will invite the first speaker in this session to give us an overview of the progress in the region, and that's Ahmed, who already started the meeting with you. And Ahmed Sabri is a technical officer working in the regional office of WHO Eastern Mediterranean region. So Ahmed, over to you.
Thanks again, Jumana. Can you see my presentation?
Yes, we can. If you can put it on full screen.
Okay.
Excellent.
So thanks again, everyone. I'm gonna give a quick update about the situation in the region. We conducted a midterm review 2 years ago, and we were able to identify some key elements about how the region is progressing, and we touched a bit about country examples and how the countries are doing in terms of hepatitis response. Let me take you first how we are gonna structure how we structured our midterm review. So as you all know, in 2015, there was the adoption of the Global Health Sector Strategy on Viral Hepatitis 2016-2021. And that strategy defined elimination, or put a target first of eliminating viral hepatitis by 2030, defined as reduction in incidence and mortality. And we all know it by heart now about those targets. The strategy also proposed 5 key interventions for countries to be able to eliminate viral hepatitis. They have to work on the prevention aspect, the vaccination of hepatitis B, the prevention of mother-to-child, blood and injection safety, and harm reduction. And in addition to that, of course, testing and the treatment. Of course, there are targets has been put for each of these intervention as highlighted for you. So this was the general framework that the Global Health Sector Strategy put for countries to be able to eliminate by 2030. With that, there was a monitoring and evaluation framework that has been developed, constructed along the result chain framework in order to assess the progress and the response at the country level. To walk you quickly through this monitoring and evaluation, it goes from the context. Countries has to measure the context of the epidemic, defined as the prevalence. They measure the system input in terms of how the testing facilities are done. Then you go to the cascade of care from prevention, testing, treatment, and viral suppression. Of course, there are indicators for each of these till you reach the impact, which is the reduction of incidence and mortality. In the Eastern Mediterranean region, actually, we tried to translate the Global Health Sector Strategy into a regional action plan. This regional action plan, we identified 5 strategic directions for countries in order to translate the bigger strategic direction that was highlighted in the Global Health Sector Strategy. So the regional action plan actually put some key milestones for countries along each of the 5 strategic directions. They have to work on the leadership and governance. They have to work on finance. They have to work on the strategic information, the service delivery, as mentioned before, and of course, health system strengthening aspect to achieve also equity for everyone. So this was the general frame that we tried to set up before we started our midterm review to see how the countries are doing in all these aspects. So for our midterm review, we put this frame in front of us, and we conducted first a desk review to see what has been published at the country level, at the regional level, from countries and from partners, to see what has been published about viral hepatitis between 2015 and 2019. sorry, 2019. And we had developed a review questionnaire that's actually constructed along the strategic direction of the regional action plan. And we had the regional consultation that was held in Lahore, Pakistan, where we brought countries together to discuss what we have find from the risk review and the questionnaire, and to discuss these findings with them, and also discuss the way forward with them. In general, in the region, 15 countries actually completed this midterm review process, whether by participating in the questionnaire or being in the consultation with us. We tried to construct the result to inform on three areas. We wanted to see how the disease burden is doing in the region in terms of incidence and mortality. We wanted also to see how the programmatic progress as per the strategic directions of the regional action plan. We wanted to see how the programs at the country level are doing in terms of setting up system to monitor how the policies, how the implementation, how the governance level of the countries are working on strategic planning or not, and we'll go into a bit of detail about that. And we wanted also to see the service delivery part, the 5 key interventions that was proposed. We wanted to understand how the region is progressing in these 5 strategic interventions. So first is the disease burden. As you see, this is about hepatitis B, as the prevalence of hepatitis B in the region is actually by 2020 was 2.5. Our region is actually coming fourth. The Western Pacific is leading in terms of the number of people living with hepatitis B. The prevalence of 2.5 could be translated actually to 18 million people in the region living with hepatitis B. In terms of the prevalence of hepatitis B among children under 5, which is actually the SDG indicator, our prevalence in under 5 is actually 0.8. And this is actually a reduction from what has been noticed 5 years ago, which was actually 1.6. So our region is progressing in this area. In terms of estimated people dying from hepatitis B, we found that 33,000 are actually dying from causes attributed to hepatitis B. For hepatitis C, we have witnessed actually in the last 5 years great efforts by countries like Egypt leading the world in this, and also some countries from our region like Pakistan doing some work for hepatitis C, which managed actually to reduce the burden in the region. However, the Eastern Mediterranean region is still leading the world in terms of how many people are actually living with hepatitis C. As of 2020, there were like 12 million people in the region living with hepatitis C. Estimated people dying from hepatitis C was actually 31,000. And as you see from the graph in the middle, the incidence is actually still the highest among WHO regions when compared to other WHO regions. So there has been some work that has been done for hepatitis C. However, more still need to be done, especially for high burden countries, which is driving the epidemic like Pakistan. So that was the first area that we wanted to touch on. The second one is actually the programmatic progress. We wanted to see how the programs are being set up to respond to viral hepatitis. So the first one is actually about the governance. As you can see, most of our countries have a focal person. They, like most of them, developed a national strategy to combat viral hepatitis. However, we were not able to tell in that aspect if this national strategy is being aligned with the global and regional frames or not. Some of them involved, managed to actually set up a strategic technical advisory groups, which convenes all the stakeholders of viral hepatitis together. However, the advocacy part is still not very strong in the region. And we have only 5 or 6 countries with advocacy strategy, and the civil society is being involved in this advocacy. In terms of the financing, which is actually one of the weak areas in the region, and countries need to strengthen that part, we actually saw that many of the national strategies that has been developed, only 6 of them were actually costed, and less than 6 were actually funded. So this tells you that maybe countries invest in the strategic planning area, but it's not actually properly followed up with the costing and actually allocating domestic resources for it. Prices for strategies for price reduction is also an important component, given the high prices of the medications and diagnostics in some countries. And we found only limited number, maybe 4 or 5 countries actually have developed a price reduction strategy and being implemented. Only 2 countries were able to attract donor funding, which is basically driven by initiatives in both Egypt and Pakistan. In terms of policies, as you can see, most of the countries actually have policies in place for blood donation, for injection safety, but in the area of policies that's actually towards the key population, we have limited number of countries actually developing these policies. However, like as you see, although as many countries actually have policies in place, the implementation of these policies is also a question mark, especially in the blood donation and the injection safety. We have witnessed some problems or like outbreaks actually that's being driven by these areas in countries like Pakistan, where we have seen an outbreak among the children for HIV. So I think implementation of these policies need to be strengthened. In terms of the strategic information, we have found that countries progressed with measuring the disease burden, and that's being defined as prevalence. And most of them maybe have set targets for the coverage targets. However, in terms of measuring the cascade of care for both B and C, and also measuring the mortality, this is a very weak area of the strategic information system that has been put in the countries. So this is an area actually that's going to hinder countries to measure the impact progressing towards hepatitis elimination. As we have seen in the first slide, elimination is defined by reduction in incidence and mortalities. And if the system in place is not able to measure this, so countries might face like some difficulties to reach this target. This is a summary of how countries are doing in terms of the five service delivery intervention that was proposed by the Global Health Sector Strategy. As you can see, for the vaccination of hepatitis B, we are at 82, not much improvement from the 2015. We were at 80%. Our mother-to-child, the prevention of mother-to-child transmission, which is the first dose vaccination, we are actually the lowest among other WHO regions. We are at 35. And this is has been an area that we have been giving a lot of focus on in the last 2 years. And we want country programs like EPI, like maternal and the child, to be working jointly with the hepatitis program actually to boost this area. The blood safety is also, we have still much work to do at our 82%, and our target is actually 100% safe screening of blood. Injection safety, as I said, implementation of these policies is actually a question mark in some countries. And the latest review actually revealed that 14% of injections happening in the region is actually unsafe. Harm reduction is also another weak area in the region. Although our target is to reach 300 syringes per person per injecting drug user, our region didn't improve much from the 2015, and we're actually at 27. Hopefully with kicking some initiatives in countries like Egypt and also scaling up this in Pakistan and other countries, hopefully this coverage will improve. For testing and treatment, I think our region actually witnessed an improvement and has been leading the globe in testing and treatment, especially for hepatitis C, mainly driven by the national screening program in Egypt. And for hepatitis B, we are at 14% diagnosis, and we are only at 2% treatment. For hepatitis C, we managed to actually reach 37% diagnosis and 33% on treatment. And again, this is driven by the national screening program that was implemented in the last 5 years in Egypt. This just to give you a quick note about how the cascade of care for B and C. For B, as you see, we are diagnosing, as I said, for like 14%, but the treatment is very, very low. So the cascade of care for B needs to be worked on. For C, we managed to boost that. However, we need some work in Pakistan because the burden in Pakistan is actually driving the epidemic in the region. And if we manage to improve the numbers in Pakistan, that will help the region much. Just to give you about the models of the initiatives being implemented in the region. We have documented 2 models, the national initiatives for testing and treatment. That's the Egypt part that I talked about. They managed to have a nationwide screening program where everybody above 18 is being screened. And now they are being extended that program to actually children like in schools. The other program is the micro-elimination model that has been also documented in Pakistan, which is focusing on geographical location or a group of people. The model in Pakistan was actually a demonstration project to prove that micro-elimination or elimination is actually feasible if we focus on some area or a population group. So in the district of Nankana Sahib, actually, they managed to target approximately 30,000 people with the screening for hepatitis B and hepatitis C, linking those who were diagnosed to actually treatment and vaccinating those who are found negative against hepatitis B. So these are 2 models that has been implemented in the region, and we are putting it forward for other countries to replicate and also learn from. In conclusion, based on our review, we have seen that our countries is actually established governance mechanisms, policies, strategies toward the elimination. However, the implementation of all this remains limited, and this could be attributed to limited financing for viral hepatitis for those countries. We have some progress in the region, especially in the area of testing and treatment, being driven by large-scale nationwide initiative in Egypt and some initiatives in Pakistan. Prevention interventions, including birth dose harm reduction, are actually still weak, in addition to testing and treatment for hepatitis B. Strategic information, we have a lot of work to do, and now we have a bigger frame to work on, which is integrated disease surveillance. So hopefully this will strengthen the element of the strategic information and will help countries to monitor their progress towards the elimination. Overall, in the region, elimination, if we continue with the same pace, elimination for the region will be difficult unless we actually put some scale to the interventions being implemented. The way forward, I think we need to strengthen the area of blood and injection safety. I think with the new global health sector strategy, there is a leveraging of the primary health care for achieving universal health coverage. And this is an opportunity for viral hepatitis in the region. I think we need models of service integration into primary health care to actually bring those services to the patients and actually help scale the testing and treatment for people living with viral hepatitis. Countries need to allocate domestic resources. This has been weak in the region, and I think we need more resources and more models like Egypt to be implemented in the region to actually move forward. Integration is also a key, and we need to work on models in countries to be scaled up to integrate viral hepatitis with other services like HIV, like STIs, like others, to actually have a patient-centered approach where the patient can actually have the services under one roof. We need to improve the area of birth dose vaccination. This is weak, and if we need to ensure hepatitis-free generation, we need to actually give the birth dose to every child that being born. As I said, we are at 35, and this is really one of the weakest, and we cannot achieve elimination if we stay at that coverage. Testing and treatment for B and C also need to be boosted, and hopefully in the next 8 years, all these elements would be strengthened, and countries in the region would be able to achieve elimination. Thank you so much, and happy to take any questions. And as Ivan said, we are, inshallah, publishing this work in one of the good journals that's accepted this, and hopefully it will come with more emphasis also on country work on the paper, hopefully in the next month or two. Thank you so much.
Thank you very much, Ahmed. I guess we will have time for some discussion at the end of this session of the presentations. Now, without further ado, we move to Dr. Sarah Abdullah. Dr. Sarah Abdullah is the hepatitis program manager in Sudan. Sudan has recently completed the costing of its operational plan for elimination of hepatitis, and she will talk to us about the challenges and opportunities in resource-limited settings. So, Dr. Sarah, over to you.
Thank you, Dr. Jumana, and good morning, everyone. It is really my honor to share this very important platform for combating viral hepatitis, and which give us the opportunity to see that there is so much is going on the world for combating viral hepatitis, and we are sharing the same concern regarding viral hepatitis. Before I will start my presentation, I would like to acknowledge that the WHO, the regional office, and the headquarter office for their continuous support, which enabled Sudan to reach this stage of presenting something that is we think it's good at the moment regarding the situation at Sudan, and we're looking very forward for more contribution and support from them. So thank you. So let me just share my screen. So it's clear now? Yes. Okay. Yeah. Okay.
In presentation mode.
Yes. Okay. Regarding Sudan, my presentation is about the costed operational plan and the prioritization and the opportunities and challenges of low-income countries as Sudan. And through this presentation, you will get to know the country profile, the hepatitis picture in Sudan, Sudan response to combating hepatitis, and the national health strategic plan development process, and the prioritization and costing of the operational plan, and the main achievements up to now, along with the challenges and the way forward. So just let me give you a brief about the area of 1,882 kilometers and 42 million inhabitants. The country is sparsely populated and shares an international border with 7 countries. It is traversed by the Nile and its tributaries, and it has like 853 kilometer coastline along the Red Sea. According to the World Bank economic classification, Sudan is classified as a low-income country. Administratively, the country is divided into 18 states and 189 localities, which represent the lowest governing level in the country. The central level is responsible for overall strategic planning, policy making, countrywide legislation, development standard and guidelines, development levels, such as planning at the state level and legislation development tailored to state peculiarities and overseeing and monitoring performing of locality governments. About the population of Sudan, the total population, according to the last census, which took place in 2008, Sudan census revealed that Sudan is populated with 39 million. According to the 2008 census, average family size is 5 to 6 members. The crude birth rate is 31 in each 1,000, and the crude mortality rate is 16.7 in each 100,000 of population. The country has a relatively young population with 45.6 under the age of 15 years and 16.4% under the age of 5 years and less than 4% for population over 60 years. Male to female ratio is almost 1-to-1. Life expectancy as birth is 58 for males and 61 for females. Regarding viral hepatitis infection in Sudan, there is no any data based on a national-wide national survey. It is the estimate of the WHO office, the EMRO, that Sudan is classified as a high endemic country for hepatitis B, and we said the averagely it is 8%, but we find that with the blood bank results that there is variation between the 18 states. Sometimes at some states you find that the prevalence is up to 20 something. So obviously that there is a clear disparities between the prevalences even among the different states. The total number of estimated cases of hepatitis B infection in Sudan until 2025 is 1,924,000, and for the hepatitis C infection is 600 are estimated to be infected with hepatitis C. Taking into account that population of Sudan in 2025 will be like 46 million, and that 30 million children already received the hepatitis B vaccine, which was introduced since 2005 through the EBI. By end of 2018, the 13 million were got vaccinated. Additional 8 million are expected to receive the vaccination by 2025. A total of 22 million individuals are expected to be protected against hepatitis B infection and theoretically not expected to contract the infection, and the remaining are targeted for these excessive interventions regarding the prevention and treatment and all of the cascade. As you can see, Sudan is hepatitis burden. We are on the top in the EMRI region with Somalia. Sudan is sharing the fairest row, and for hepatitis C, we are in intermediate endemicity for hepatitis C, or in the intermediate tier. So the routine blood bank data for screening of blood donors is giving some clue. As I said, it is the overall proportion of donor reactive for B range between 3.6 to 4.8% and between 0.6 to 2 for HCV, which is slightly going with the estimates for the B and for the C, sorry, and for B it is because they are screening already. Not a high-risk group or the screening norm, or let us consider them as free from infection population. So at the state level, the activity might reflect increasing burden of post-hepatitis B and C infection in 12 states already. We took them as a high priority to intervene much. Sudan response to combat viral hepatitis. Actually, we could consider the response started since the introduction of the pentavalent vaccine and the hepatitis vaccine within the pentavalent since 2005. But from the perspective of a program or like a disease program that is running in the Ministry of Health, in June 2015, Federal Minister of Health officially integrated the viral hepatitis in Communicable Disease Control Directorate mandate. And in 2016, DCD, which is the Disease Control Directorate, in collaboration with Sudan WHO office and the National Center for Gastroenterology and Liver Disease, developed a roadmap to establish and integrate viral hepatitis control through 2016, 2018, guided by the WHO Regional Action Plan, including development of the Sudan National Health Sector Strategy on viral hepatitis, which then endorsed in 2019 as the first ever national health strategy plan to fight viral hepatitis B and C by 49 national stakeholders at the endorsement. So, for the National Health Sector Strategic Plan development, the goal of the strategy is to pave the way to eliminate viral hepatitis by 2030. The guiding principle was the core for developing this strategy was the core to be considered, as it is going to strengthen the implementation of this strategy, and took it really forward and bring it to the practically on ground. The political commitment and leadership role of government in hepatitis control response, effective partnership and multi-sectoral involvement, which was very clear in the development of this strategy. Since the beginning, we called all the stakeholders by stakeholder analysis, and we brought them on the ground to develop this strategy together, along with the operational plan and then the costing. Involvement of patients affected by viral hepatitis on all aspects of the response, the promotion of human rights and removal of structural barrier for access to services, and evidence-based approaches with its clear mechanism for monitoring progress, and universal health coverage, definitely efficiency and value for money, sustainability and decentralization and integration. Here, the expected outcome from this strategy or the strategic objective, we listed like 9 strategic objectives: establish and integrate, coordinate, and capacitate viral hepatitis response, and to strengthen functionality of the viral hepatitis monitoring and evaluation in the essence of the information for focused action, and to ensure protection of target population against hepatitis. And you could see that we hit huge targets, which we revisited again this year for so many reasons that I will mention in the challenges. But to achieve an impact by 2025, those were the already set target for that goal. So 100% of blood transfusion safety, and ensure delivery of evidence-based intervention for BMTCT, behavior change intervention, and condom and lubricant program, ensure early detection of viral hepatitis B and C cases, and treatment of viral hepatitis patients. Action plan and prioritization. The strategic action plan composed of like 806 activity that address all the strategic interventions specified for the strategic objective, the expected outcomes. And later we extracted like 400 activity were prioritized based on the substantial role in establishing the response. Following development of the complete set of activities of strategic intervention of the viral hepatitis strategic plan, a 2-year plan, operational plan of high impact intervention was selected from the master operational plan for costing purposes. And definitely for implementation purposes also, because we prioritized like a 2-year plan for 2022, 2023, and then going to do like a mid-term review to evaluate our work, considering the implementation that was hindered by a lot of challenges since the development of this strategy. So the costing exercise estimated the additional financial definitely investment that is required for implementing this strategy. And it was done by two tools, the one tool, health tool, and the Excel template for estimating the other cost for the other commodities rather than the one health tool was used for estimation of the cost of all material supplies, vaccine, drugs, investigation material, and other supplies required in the implementation. And the Excel spreadsheet were used for costing program, dedicated human resource infrastructure and program activities. Costing was done by strategic direction, priority area, strategic objective, strategic intervention, and even detailed plan of activities. And we came out with 2 scenarios for the costing at the end. The scenario in which mentioning the cost for all the intervention, entire package of intervention mentioned in the operational plan. And then we have the scenario 2, which was omitting the other the other allied objectives regarding other which have a cross-cutting areas with other programs that could be managed by other programs, and to just see the cost, the variation between the two scenarios. So scenario one, as I mentioned, the total cost of implementation of the operational plan in 2022 is estimated to be around $21 million US dollar in 2022. With the scaling up of intervention, it will reach 45 million US dollar by 2025. And for scenario two, the cost for the first year or 2022 is 8 million US dollar and scaling up to $30 million by 2025. The slide here is showing that how did we reduce for the implementation of the 2-year plan, we reduced the target so much in order to have like a realistic targets. And if we established a real robust program, then we could add more targets, and we could the idea is to launch the program, to establish a organized and comprehensive program to cover all the objectives, and then we could add as much as target as we can. Here is my last slide, which is about the achievement, challenges, and the way forward. I think considering the situation in Sudan, really it is hindering the implementation, and we hardly achieve those achievements. Now we have a costed operational plan catalyzed to 2025. National treatment guidelines. Actually have the second, this year we updated the national guidelines, which was developed right directly after the strategy, and we are updating it now, and we are going to endorse it by the next week. Inclusion of viral hepatitis services within the essential health benefit package in order to hopefully to be covered with the health insurance or any financing for the packages of health services that is needed in Sudan. Inclusion of hepatitis bears dose in the EBI, which was approved, and it's in the pipeline for 2023. And inclusion of hepatitis vaccination for adolescent in the adolescent national strategy. The challenges, as you all know, the instability of the political situation and the COVID pandemic hindered the implementation of this strategy since 2019. We did not do as we planned. And nowadays, we are continuing having this civil unrest and the instability of the whole political situation and so on. Insufficient domestic support and no donor support apart from the vaccine yet. The diagnostic test and treatment are not affordable or accessible for the most of the population. So patients always get the treatments out of bucket definitely, and even for the diagnostic, it's really burdening the patients. And for the way forward, we are looking to mobilize definitely. There is a much way forward plans, but those are the most important ones. We are trying to, or we are planning to do a huge mobilization of resources from the national and international resources, strengthening the service delivery component, which by expansion of the services and to ensure the quality of all the service delivery components, strengthening the prevention of mother-to-child transmission in an integrated manner with HIV and STIs, strengthening the laboratory component along also with HIV and STIs toward robust laboratory network for the 3 diseases. And one point not mentioned here is to strengthening the information system for the programmatic and the surveillance data within the National Health Information System. I know that Sudan is away from the elimination by 2030, but we are looking really forward to eliminate by 2030, especially that we have a lot of opportunities to hit And I hope the next time we came with great achievements on ground and more toward elimination for 2030. Thank you for listening, and over to you.
Thank you very much, Dr. Sarah. So this is a really comprehensive overview of your action plan, operational plan, and targets. So we will have time to discuss that also after we finish with the presentations. Now, another energetic woman lead of hepatitis program. We're not short of women here. Dr. Ibtissam Khudri from Morocco. Program manager, hepatitis and HIV program manager in Morocco. She will be presenting to us the revision of targets based on epidemiology and the implications on implementation. So Dr. Ibtissam Khudri, welcome, and over to you.
Sarah, please. Thank you very much, Jumana. Hello, everyone. I'm very happy and I'm glad to participate with you during this EMRO session in order to present the main results of a very interesting and exciting exercise at country level that we have undertaken with the help of WHO and also CDA team in order to update country targets for hepatitis and refocus the national response based on the results.
Can you please put your presentation on presentation mode?
Yeah. Is it okay? That's fine. I think it's okay.
Yes, thank you.
Okay. So I have said that Morocco has done in 2019 its first national survey for viral hepatitis, and the results of this interesting study helped very good to update the national targets for a better response on hepatitis B and C, and under for sure the national strategic planning that we have developed with the help of WHO in the I think several years ago. So now Morocco has its first national strategic plan for viral hepatitis because we know that hepatitis represents a major public health problem in Morocco. We'll see later the prevalences for B and C and also for A. And we also Morocco have benefited from several medical progress that are favorable to implement this national strategic plan. I mean by that the availability for the AA for hepatitis C, for example, availability of rapid tests for screening, availability of new technologies, for example, for fibrosis evaluation and so on. And also because viral hepatitis now represents a new area for advocacy in the country. So Morocco is now ready to implement this national strategic planning. In addition of that, we have now available the results of the first national prevalence survey for viral hepatitis B, C, and A that we have done in 2019, a nationwide study that enrolled more than 12,000 participants. There was household participants, and the results, the main results are represented in the table in front of you. So for hepatitis B, prevalence for antigen HBS is around 0.7% nationwide. And we can see, for example, that this prevalence become much higher with the older age. For example, for 40 and plus, this prevalence jump to more than 1%. And this is a very issue to take into account if you want to put in the country a strategic screening strategy to against hepatitis B. We see also that there is some difference between male and female, some difference with the rural-urban area, some difference with the repartition with the gradient north and south country, and these data are very helpful. Sorry? Okay. So I said this data are very helpful for a strategic point of view to take into account when implementing screening and also a treatment strategy against hepatitis B. For hepatitis C, also data are now available. The national prevalence for hepatitis C is around 0.5%. And this is, once again, this prevalence become much higher for older age. And there are also some difference with the sex, regions, and also medical coverage. We have also remarked that participants who had a medical coverage presented a prevalence much higher than those who doesn't benefit from a medical coverage. For hepatitis E, we have also tested IgG, sorry, just for to try to answer a question in the country: should we introduce or not a vaccine for hepatitis E? And this issue is now still on discussion inside the National and Technical Committee for Vaccination and Viral Hepatitis inside the country. But we have found that the prevalence, the national prevalence for hepatitis A was of 88%. And for children, for example, it is around 60%. So we are still looking for other data in order to decide together in a partnership how we could deal with this data and see if we are if we need to introduce vaccine or no for hepatitis B. This was for a national consideration, but with regard to high risk groups for hepatitis C, for example, we know in the country very well our epidemiology. So we have data available for prevalence of hepatitis C, among different high risk groups. And we know that this prevalence is much higher among PWIDs. For example, it can reach 70%, for example, in some area in the northern country. Hemodialysis patients, hemophiliacs are also people at high risk. And we have also people living for HIV, STI patients. So we have data among all this population. And for sex workers, MSM, and migrants, we are now this year introducing hepatitis B and C systematically in all the IBBS studies that Morocco is doing routinely in for HIV programs. So we'll get results very soon available for this risk group population. So I said we have a national strategic plan that have the same vision and same goal than the global sector strategy and also the regional action plan. And we have also determined our areas of interventions with the main interventions, the main actions, and also we have set an action plan for the next years. We are also did a costing with the main actions and the interventions, and this national strategic plan englobe all hepatitis for sure, with a main focus for C and also for B. So we have interventions related to prevention, screening, diagnosis, treatment, and also epidemiological and research considerations, and also partnership and governance consideration. And we have also defined some guiding principles to implement this strategic planning. But the main question that we have asked in the country once the results of the first national serosurvey were available is how we can use these results to update targets of the national NSP and make sure that those new targets will set the global health sector strategy targets and lead Morocco to elimination around 2030. So for that, we are really thankful for the WHO, EMRO, and also country office and the HQ, sorry, and also for CDA team, Center for Disease Analysis, and because we have undertaken together an exercise of modeling public health and also economic impact of hepatitis C, but also hepatitis B treatment in Morocco in order to make sure that the new targets will really lead to elimination in 2030. And we have also used this very interesting results that I will try to present in the next slides to make it as an advocacy documents for policy makers in order to launch this national strategic plan that is planned for the next this year, inshallah, around July 28, around la journée mondiale. En tout cas. So we have modeled 3 scenarios with this exercise with WHO and CDA and also expert national team. The first scenario was a baseline scenario. It means to do nothing, still continue screening and treating with the same paradigms actually and without any additional intervention. And we'll see what will be the results. And we have also tested 2 other scenarios endorsing the global health sector strategy targets and screen systematically all persons aged over 35 years and over. Why 35 years and over? It's because this scenario was designed to complement the HBV screening program by accounting for a younger HBV infection population. So that's why we have reduced to 35 and plus, and we will see the results. And we have also modeled a 3rd scenario by screening 40 age and plus participants. Why 40 age and plus? Because the majority of viremic infections for hepatitis C in Morocco are in ages 40 and plus. So that's it. So with the first scenario, sorry, just need to, yeah. For the first scenario, we see if any additional intervention will be done in the next year. So in the absence of any intervention, annual treatment is estimated to drop by 50% over the next years, because treatment numbers are assumed to decline as treatment-seeking patients are depleted from the pool of diagnosed and eligible patients. And we see also that very few efforts will be done in screening programs, etc. And the main result is this scenario will not help to make elimination in 2030, because any impact will be shown for new infections and also deaths and morbidity for HCC and decompensated cirrhosis. The second scenario, endorsing the targets global health sector strategy and screening 35 persons and over, we see that we should make more efforts in screening, and maybe we can, for example, do more than 2 million tests, screening tests nationwide to find more patients to diagnose and treat. And then we should annually treat over 10,000 people. And this will actively reduce new infections by 20% annually. And we see clearly that this scenario will help to set the global health sector strategy, and we can have a great impact on new infections, on morbidity and mortality for hepatitis C in a general manner. The same for the third scenario when we would want to screen patients over 40 and plus. We should once again screen around 2 million persons per year, and we should treat more than 10,000 people aged 40 and plus, and we can have an impact for morbidity and for mortality, and we are sure that we can eliminate using these targets and these goals. And we had illustrated all this with these graphs. We can see the three scenarios with the impact on infected cases, the compensated cirrhosis incident, and also deaths. And we know that if we choose the second scenario, for example, for screening 35 and plus, we will ensure that we'll achieve the targets, and new infections will reduce by 80%, and liver-related mortality will reduce by 65%, and more than 4,000 lives can be saved. So we are now sure that those targets will take the country on the right way. We are also try to test the economic impact, just to have an idea how it will cost, and to have an idea also about the return of investment in which year, for example. So we have calculated all this, taking in consideration the three scenarios, and we have found that achieving the global health sector strategy target could cost between 2 billion dirhams. It means $0.2 billion, for example. And if we take in consideration all the efforts that Morocco is actually undergoing with the local manufacturers in order to reduce pricing for DAAs, for example, so we can be sure, if we can endorse this eliminating pricing scenario, that the result this will lead on an immediate return of investment by 2023. So this is also an interesting scenario to implement in the country, and very encourage us to continue efforts for advocacy to reduce prices for the AAs, for example, and also prices for clinical exams. The same exercise we have done it for hepatitis B. So we have modeled the three scenario, the baseline, and also screening 35 and plus, and also 40 age and plus. And these are quickly the results, so we can find an impact if we can endorse the second or the third scenario. For example, if you want to screen 35 patients aged 35 age and plus, so we can see that the total infections will decline by 10%. New cases of HCC would increase by 25%, and mortality will be increased by 10% compared to the baseline. We can have HCC, for example, more than 1,000 cases that can be averted, and also we are sure that we can save more than 1,000 lives affected by hepatitis B. We have also tried to model a scenario for vaccine, for prophylaxis coverage for hepatitis B. And we have modeled the baseline prophylaxis using the achievements that Morocco have till now. But we know that in Morocco, we have still some difficulties for bird dose vaccinations, because we have much reticence in hospitals, inside hospitals, to vaccinate children at birth. But we have once again tested the WHO prophylaxis coverage targets, because we have now introduced hepatitis B inside the national world map for eliminating transmission from mother to child for HIV, syphilis, and also hepatitis B. So we know that we have to grow and really find solutions to make the coverage for bird dose much higher than 40%, for example, in 2019. And we have proven that
Dr. Kisam, can you please try to wrap up in the next 2 minutes?
This is my last slide.
Thank you.
So just to say that this scenario will really help to reach WHO goals, and we have no problem, alhamdulillah, with the antigen HBs prevalence among 5 years old. So these results encourage us to really endorse this scenario and work together to make it real in the real life. So that's all. So I want to once again to thank you for your attention, and also thank the expert panel participants that helped us to make this exercise easy, and also make results available for country level. Thank you very much.
Thank you very much, Dr. Kisam, for sharing this presentation and the information in it. I'm sure it can solicit a lot of queries from the participants in this panel. So the next presentation is basically from civil society in Pakistan, Punjab, where the private sector, represented by the Association for Social Development, with the Punjab Hepatitis Program, could lead to set the ground for scaling up testing and treatment and vaccination against hepatitis B. So Dr. Ahmad Khan, Mohammed Ahmad Khan from Association for Social Development, the floor is yours, please.
Thank you, Mana. I'm just going to quickly share my screen. I hope everyone can. Yeah, is this visible to all? Can everyone see? I hope everyone can see my screen. I'm just going to go ahead and continue.
Yeah.
Hello, everyone.
Dr. Ahmed, I think your connection is a little weak.
And I'll be presenting the public-private partnership experience of hepatitis treatment in Pakistan.
Dr. Ahmed? Hello? Dr. Ahmad Khan? I don't know if you can hear me. Your network is not so strong. So if you can please turn off your camera, maybe that will help.
Yes, hello. Yes, I'm trying to switch.
Dr. Ahmad?
Yeah, I'm so sorry for that. I was just quickly trying to change my network. Can you hear me now?
Yes, we hear you.
Yeah, so sorry. All right, I'll quickly get started. All right, so hello, everyone. I'm Ahmed Khan, and I'll be presenting the public-private partnership experience of hepatitis testing and treatment in Pakistan. All right, so this project was a joint collaboration of the Punjab Hepatitis and Infection Control Program, the Association for Social Development, and the Nuffield Center for International Development, Health and Development at the University of Leeds. This is, of course, supported by the Hepatitis Fund and the Department of Health, Punjab. All right, to provide a bit of background about the organization, the Association for Social Development was established in 1995 as a not-for-profit entity. Some of the health conditions that we've worked on include TB, malaria, hepatitis, mother and child health, non-communicable diseases, mental health, and child development. We've developed and generated evidence on multiple contextualized healthcare interventions. Some of our development experience includes development of case management desk guides, staff training, patient educational tools, digital applications. Our evaluation work includes cluster randomized trials, qualitative studies, costing studies. All right, so to provide a little context of the healthcare in Punjab, Punjab is the most densely populated province of the country, with a population of 110 million in 36 districts. So the primary level healthcare in Punjab, it consists of about 315 rural health centers, which consist of multiple medical staff and a basic lab service, and about more than 2,500 basic health units, which consist of a medical and allied staff without a lab. There are more than 160 secondary level hospitals and more than 45 tertiary level hospitals. Obviously, there's a network of private clinics and hospitals which is regulated. As I'm sure most of you know, Pakistan has the second highest HCV caseload in the world. In Punjab, we have a prevalence of about 9% of HCV, which is mostly genotype 3. The estimated caseload for HCV is around 10 million, while 2.5 million HBV cases. All right, so more than 150 public hospitals with the support of the hepatitis control program have already been established that are already delivering hepatitis care at established hepatitis clinics. So these clinics at each hospital have a designated doctor and a nurse, and the care being provided includes rapid and PCR testing as well as drugs and So obviously the hospital care settings provides a access challenge for the rural population. The main challenge to hepatitis C care in Punjab is the lack of an integrated hepatitis C care model at the primary level facilities. There is a lack of a replicable evidence-based intervention to deliver integrated HCV testing, treating, a link with lab at hospital and PCR, expanding the EMR, that is the electronic medical records, to the primary level facilities, and of course, monitoring of that HCV care performance. The program needed technical support to address this HCV care gap at the RHC level. So this project, this public-private partnership activity was to develop, pilot, and evaluate the delivery of an integrated hepatitis C care at primary level health facilities. So there were 4 phases of the intervention contextualization and the preparation, the care implementation and monitoring at RHCs, the expansion of HCV screening to the BHUs, and of course, the evaluation and sustaining of HCV care at RHCs and BHUs. The integrated HCV care package that we developed included contextualized HCV test treat guidelines, training modules for doctors and nurses, pictorial counseling tools for patients, adapted recording and reporting tools, and EMR. The regular staff and the regular doctor and allied staff were engaged in the HCV care at RHCs and BHUs. And of course, we linked the existing healthcare resources, including LFTs and CBC testing at hospital labs, the available centrifuge machines and refrigerators at RHCs, and the PCR testing at central lab. The intervention developed jointly by the program, district health, and the civil society partner. That was us. So the collaborative material inputs were, we provided the material inputs, we supplemented some of the rapid testing kits, we provided cool boxes, and we supplemented some of the PCR testing for the initial few months of the project. The hepatitis control program provided most of the rapid testing kits. They covered the cost for the PCR testing after the initial few months. Of course, they provided the antiviral drugs and the hepatitis B vaccine. The district health offered hospital lab support, care monitoring, and the centrifuge and refrigeration facilities at the RHCs. So all 48 RHCs in 6 selected districts of Punjab were enabled for HCV care. This enabling included staff training, supplies, monitoring systems in place, and care linkages established. So about 44,000 individuals got rapid tested. Around 15,000 or 34% of those tested were found reactive. All of them got PCR tested. Around 7,200, which is about 48%, got confirmed. And around 88% of those confirmed cases got registered and started treatment. So of the 655 individuals that got tested for sustained virological response, around 96% were found to be SVR. So encouraged by these preliminary results, we thought of expanding the hepatitis screening one step further down to the BHU level. So every BHU caters to a catchment population of about 20,000. There are around 8 to 10 BHUs associated with each RHC. So we linked screening at BHUs to testing and treatment at the RHC. So we enabled around 461 BHUs in these 6 selected districts. Around 2,600 individuals got rapid tested, and around 24% of them were found to be reactive, and then further got referred to the RHC for further testing and treatment. All right, so the evaluation of this integrated HCV care is currently in progress, in process. I'm sorry. The purpose was to learn about the scaling of HCV care, and this covers obviously the care provided, the care enabling at RHCs and BHUs. So the evaluation method will be a mixed method design. The quantitative data will reflect the effectiveness and cost effectiveness of the intervention, while the qualitative data will reflect on the fidelity, the protocols, the feasibility, and the replicability. The program and the organization jointly designed and will conduct the evaluation with the help of external evaluators from the University of Leeds. Some of the key learnings based on the preliminary analysis shows that integrating HCV test treat at RHCs and HCV screening at BHUs is both effective and feasible. And through shared public and private responsibility and resources, we can optimize the results. It's efficient and feasible to link HCV care with the existing healthcare resources. Some of the key challenges that we faced were competing strategies and approaches to universal health coverage. For example, facility-based versus community-based screening, and of course, delivering safe hepatitis care in the context of COVID-19. Some of the future considerations are to explore donor-funded scaling in all 36 districts of Punjab, and to expand, if possible, this integrated care to 29 districts of Sindh province. Other than this, we are exploring community-based active active HCV screening and linking them obviously to the already established care at BHUs and RHCs, and expanding this hepatitis care to private hospitals and clinics. We're also exploring measures to enhance community engagement in this prevention and treatment care of hepatitis C. So yeah, so lastly, I'd like to thank all the organizations of this wonderful summit for providing us a platform to share our work on such a global scale, and of course, for others to learn all the great work that's being done around the world. And lastly, a big thank you to all my colleagues for bearing with me. So thank you.
Thank you very much, Dr. Ahmar Khan from Pakistan. Actually, that's a different model that we have seen of operation from the two other presentations. And we're actually a little late for our time, but I see a few questions coming in on the platform. The first question, if we can have some quick answers to those questions. The first question comes to Ahmed, and it's about asking how complete was the country level data sets and the challenges faced, and how you mitigated the lack of data. So if you use triangulation or other sources. Ahmed, over to you. Can you please answer in half a minute, not more?
Yes, so as you saw in the strategic information slide, there was some difficulties in the countries in monitoring, especially the cascade of care. And the data that came actually about the numbers of those tested treatment, it didn't actually help us to triangulate a regional picture. So we relied much on the estimates being published from modeling, and those were published by WHO and other partners. In general, the level of data in the countries is not very strong yet. Countries can measure prevalence and those from surveys from previous times, but now they are challenged in the cascade of care and mortality and incidence measurement. Thanks.
Thank you, Ahmed. The second question is from Nicholas Luman. And the question is to Sudan and Morocco about the testing strategies that are described and that are based on age criteria. He's asking whether considerations for testing high-risk populations independent of age is on the radar of your work plans. So I start with Dr. Sarah, then I pass on to Dr. Tissam.
Okay, thank you, Dr.
Shumana, can I answer?
Prioritizing high-risk groups. Okay. Sorry, yeah. I was just saying that definitely we have already prioritized like 10 high-risk group, including the key population and patient on dialysis and patient living with HIV, and along with other special group like pregnant women and hemophilia patients. And last coming the contact of the already hepatitis, non-hepatitis patients. And definitely those are on the top of the list for interventions as a priority group, top priority group.
Okay, Dr. Tissam.
Yeah, Jumana. So yeah, for the question of Niklas, for sure the criteria of age was put for general population, but for high risk groups, we are trying to test everybody who is aged over 18 and plus, because we cannot test minors yet. For different consideration, we need consent, parental, etc. So yeah, there is no limit age for high risk groups, but for general population, yeah. Thank you.
Okay, thank you very much, Dr. Tissam. And the next question is to you, also coming from Shaima Al-Safuri. She's in the regional office of WHO also. She's asking about the difference between the second and the third scenario in terms of number of lives saved, and also the cost of both. The second is more costly. So what is the difference there?
Yeah, thank you for the questions. Yeah, the main difference between the two scenarios is that the second one, we are sure that we'll tackle also a HPV consideration. So we will sure if you would want to couple screening for B and C, that will cover the main groups that have higher prevalence. In terms of costing, for sure, the scenario 35 and plus will cost more, but it will be a small difference, around 20 million dirham, $0.2 million. And in terms of impact on lives, it will not be a great difference between the two scenarios, but we will be sure for C, for example, but for hepatitis B, the difference will be considerable.
Okay, thank you, Tissam. And the last question will come live from Dr. Gamal Shiha. And with that, I will hand over to him the moderation of the rest of the session. I thank the presenters and the participants very much for your engagement with us and for sharing your experiences and putting on the questions, which are certainly enriching and help more understanding. So over to Dr. Gamal Shiha. You can ask your question, get the answer, and then continue moderating the rest. Over to you.
Thank you, Dr. Jumana, and thanks to all the speakers. I have a question to Dr. Ibtisam about the prevalence of hepatitis B in Morocco. I noticed that the urban regions have higher prevalence than the rural. 0.6 in rural areas, 0.4 in 0.6 in urban areas, 0.4 in rural areas. How can you explain this? Because in the majority of countries, the reverse is the case. Can you explain?
Yeah, your question is very good. In fact, we don't have a clear explanations. These are just some assumptions to explain those results. Maybe persons from urban areas have more access, for example, for risks factors, because during the same study we have identified a lot of risk factors. For example, medical dentists, for example, using syringes, etc. So we think that people from urban area maybe are more exposed to risk factors than rural area, but I think we should need other studies to have a clear answer for this. Thank you.
Yes, thank you. And one comment to Sarah from Sudan. Is there any rule for the civil societies in your program? I noticed that from Sudan, we don't have a patient association working with us in fighting viral hepatitis. Is there any active association or civil society working with you?
Yes, Dr. Jamal, actually, yeah, the role of civil society is not yet well established. We have only one a patient association, which is for the liver transplanted patient. And their scope of work is only to support this small network, but they are not doing yet any part for the advocacy, and definitely they were included in the development of the strategy, and they were considered for to be strengthening during the strategic period, to have a bigger role in advocacy and prevention of to do like a more role for the community under the community participation.
Thank you, and we would like to have contact with them. And with this, we start our panel discussion about hepatitis B elimination, the need for aligned approaches. We will have with us Pakistan, Afghanistan, and Oman. And we will start with Dr. Sophia Yunus from Pakistan. Dr. Sophia, are you online?
Yeah, I am. And good afternoon from Pakistan.
Good, and nice to see you. And I have a question to you. If you allow me, I want to know what are the key policies and the strategic shift to bring hepatitis B birth dose and third dose to scale up in your area? Please.
Thank you so much. And first of all, I must thank you for inviting me to this forum. And, Pakistan has introduced hepatitis B in its immunization program since 2002. And since then, it was initially given as a standalone, then followed by in 2009, when pentavalent vaccine came, it was given at 6, 10, and 14 weeks of initial life. So in this regard, we were very much covering the childhood vaccination, but birth dose was not considered at that time. And now, as we are a Gavi eligible country, so there was also a parallel program running in Pakistan that was a hepatitis control program, and that was procuring vaccines for their healthcare workers. And they were delivering this vaccine to the health facility where the births were taking place, and they were, registering the coverage. So EPI program was running in parallel, but now with the passage of time, considering the integration and going forward towards a healthcare system strengthening approach, country is very much targeting to have, all the vaccination programs aligned in such a way that we reach the maximum number of population. Initially in 2017, we tried to, bring all the programs together. Like for hepatitis control program was procuring the vaccine. We offered that we will be here to provide immunization supply chain management for all these vaccines. But the fear among the provincial managers was that it would be difficult for them, as the EPI centers are not situated at the birthplace. So it would be difficult for them to get the children vaccinated immediately after birth. And also the EPI centers were not 24/7. So what Amar was presenting was regarding the healthcare facilities that in Punjab have shifted to 24/7. So with this shift, there was an opportunity to align MNCH program with EPI program and to move forward. And in this regard, Punjab has made progress. And last year, the government of Punjab procured around 1.8 million doses of hepatitis B birth dose. And in close collaboration with MNCH program, all the birthing facilities were given this vaccine. And currently 50 to 60% of all those births. So it is just a period of, 8 months that we have made such progress that around 50 to 60% of the births that are taking place in the health facilities are being catered to with hepatitis B birth dose. So the national government is now looking forward to the coming project projects in which all the programs are coming together. For example, the National Health Support Project, in which it is envisioned to strengthen the health system, and where EPI is also part of it. And we see that as we move forward, more and more we will get programs. The other provinces will also learn from what Punjab is practicing, and we are going to expand it. Sindh is still using the vaccines that are procured by Hepatitis Control Program. So I think this Punjab experience would help us to document lesson learned, that how different departments can collaborate for a national introduction of hepatitis B bird dose. Thank you.
Thank you very much for your answer. And now we are moving to Afghanistan. Dr. Dilaur. Dr. Dilaur, are you online with us? Dr. Dilaur?
Actually, Dr. Dilaur is replaced by Dr. Ihsanullah.
Dr. Ihsan?
Yes, thank you. First, that I will just deliver the message from Dilaur, the new program manager. And he sent me an email, and he called me that's based on some urgent issue which was received by director, that he will be not able to attend this meeting. So he nominated me and called me that you will represent me, and please accept that I has apologized for not attending.
Welcome, Dr. Ihsan. Welcome, Dr. Ihsan. And we want to know the progress and challenges in scaling up the hepatitis B birth dose and the third dose in Afghanistan. What are the challenges in the immunization program for hepatitis B in your area?
As first, I was not in whole picture. That what was discussed among Ahmed and Dr. Dilaur, that's I joined this meeting. Just for your information, the availability of the birth dose, as you mentioned, it's already included in the API section. And it is distributing from all health facility through the Sihat Mandi, all the comprehensive health center, and also even basic health center, BHC, and all regional hospital. And in the vaccination program, it is already integrated, and regulars, they follow this issue with other vaccination, as with measles, with other polio. This is, we have this the access, and also it is distributing, and even for all the clinics and through other to the villages, to the at the birth dose. It is definitely it's implementing right now. We have Afghanistan has this opportunity that the birth dose is implementing. But regarding the issue mentioned, it's still we didn't hear a challenge for the stock out or for the cold chain and all for this, and even in private sector it is right now it is available. And if there is some other challenges in the pictures, we will share in the follow-up meetings maybe, but right now the progress is good. And the receiving of the birth dose is including of the part in the private sectors, in all governmental hospital, in all BPH system, it's implemented. But still, we haven't faced any challenges for this. But the issue is for the and hepatitis vaccination is for the adult. This is the lack. Still, we have no access to provide the hepatitis B vaccine for the adults. For the child, in the API program for immunization program, it is already integrated. Thank you.
But in Afghanistan, there is no national program for vaccination of adults. You don't have this.
Yes, we have the national EPI program, national immunization program. It is active. It has that's I mentioned the hepatitis or the birthdays for the child. It is included of that.
Good. Now, considering the situation in Afghanistan, is there any difference in this service in different areas according to the security, the safety?
One good thing that the security right now for the implementation is such program. It is good. It is not a big threat that to be someone not good to the remote area, because right now is a one government and one government administration. We haven't heard any security threats to be for the vaccination. Just a few months before, there were some information that some of the vaccinators was face problem in one province of the Afghanistan, but that people also the issue was also covered by the new soldier. But for the security situation, there is no big challenge.
It's not affecting your work.
Yes, it's right
so
now.
You can cover all areas on the same level.
Okay, exactly. All the same areas in urban and also rural. There is no problem.
This is good news. Thank you very much, Dr. Hassan. Thank you.
Yeah, thank you. And also for other issue, if you want, that's other progress in hepatitis, especially for the treatment hepatitis C in the guideline developments, that please let us know. We can to explain and to discuss.
Yes, if you can give us more idea about the coverage as regard treatment. Is it available? Is it in the health insurance, or people pay the cost? Is it affordable?
Yes,
give us an idea about the situation, because this is important.
Yes, maybe WHO collects on the pictures that the hepatitis program was even since 2007, we had integrated activity with harm reduction and a package of harm reduction for the HIV/AIDS. For the HIV prevention and the harm reduction, which has 9 components. One component were hepatitis, and we had only the prevention services, especially the clean needle and syringe, was distributed to the key population or the injection drug user, because right now the hepatitis C is more among the people who inject drug, but the harm reduction right now covered this prevention. And also after that, in 2019, the program even changed to the Afghanistan National AIDS Program for control of AIDS, hepatitis, and STIs. Right now we are calling ANPAR. So after that, we brought some other changes. We included the treatment for hepatitis C. And also we started the vaccination for hepatitis B. And also, fortunately, that's in our Global Fund grants, before to develop the concept note for the HIV, that's by the full support of our WHO colleagues also in IMRO, Dr. Jumana, and we appreciate that. They supported us for the consultant, and for the first time we developed the hepatitis strategy and the integrated hepatitis strategic plan for HIV, hepatitis, and STI. That is effective up to 2025. We have this strategic, and also since last years when the new government came, just some of our activities are affected, and for example, we didn't purchase the hepatitis C treatments, but previously we had in our program that around 1,200 HCV positive client treated, and also for 5,000 KIPs B vaccine implemented, and also for this year we are in the close coordination with the MOPH leadership that's to restart the hepatitis C treatments. In addition to this, in last years, by the support of our regional WHO colleagues and also EMRO colleagues, the hepatitis C and B guideline developed. And B guideline especially developed by our technical staff here in Afghanistan. In these two guidelines, B and C is already translated to the local language. And right now we have these two guidelines that were recently developed. And also for the other issues, prevention and harm reductions, the clean needle syringe program are implemented for the prevention purpose. And for the treatments, we are trying that's to purchase or to plan. And even we started the process with the government authority, with the Ministry of Finance, that's to allocate a budget for the C treatments. But still we don't have, but just this is the planned activity. And also we are in the close coordination with our WHO colleagues, that's to support us in the capacity building or the technical issue. And maybe in the futures we will have a training for hepatitis B as well, because the guidelines is recently developed, and maybe this will be also translated to the local language. That was just the overall brief from Afghanistan, that we have some opportunity that still we are working close with the WHO colleagues, especially in a technical section, as we mentioned, for the development and the guideline, and even sometimes for some medicine as well. We are in the communication with UNAFs and other. And if other some progress came, we can share that as well. But right now, our national AIDS control program is Afghanistan, a national program for control of AIDS, hepatitis, and STI. So we are working for these three communicable diseases, and we already have some support from the government side as well. And also one thing that I will share for your information, recently UNITAID called for a proposal for the hepatitis C treatments among prisoners and injection drug users. But after the struggle and after our efforts, we can convince the fentanyl AIDS, and so Afghanistan also included on that part to be one country of that proposal to be developed. And the proposal was developed by the fentanyl AIDS and by the consultation of some international consultants, and we are now waiting for its acceptance. It is accepted that we planned some activity, especially among injection drug users and prisoners for the treatment and hepatitis C, or from my side.
Okay, Dr. Ihsan, thank you very much for this information. And now we move to Oman. Dr. Jamila. Dr. Jamila, Oman has a high coverage of hepatitis B dose and third dose. What was the role of MCH program in achieving this high coverage in your country? Dr. Jamila.
Thank you, Dr. Kamal. Good afternoon from Oman, and it's my pleasure to be with you in this panel discussion. Thank you for the invitation. Before focusing on the role of MCH on the increasing coverage of hepatitis, just as a brief background about Oman, maybe some they didn't know about Oman. Oman is one of is considered now as a high-income country located in the southeast of the Arabian Peninsula in the Southeast Asia. Before 1970s, Oman was underdeveloped country, but however, in the last few decades, Oman achieved a tremendous development, which was recognized by the international organization, and the development and improvement in all indicators was attributed to investment in health and education. When you're focusing on health, the key elements in the development in health in general was integration of the service and program at primary health care, including the mother and child health program and the EBI program, hepatitis and HIV. we have a good collaboration and coordination between the maternal and child health program with the EBI program, the program looking after HIV and hepatitis in planning and coordinating of implementation. When we implement a program, we are not implementing them as a vertical program, we are implementing them as a package of service. So all programs are integrated together at primary healthcare as a package of service. For mother and child health, we encourage all women, once they know that they are pregnant, to register to their parent health institutions for a purpose of following up the pregnant woman during pregnancy, deliveries, and after during the postnatal, as well as to follow up the child, especially when it's coming to immunization. We succeed that to our mothers, pregnant women we have a coverage of more than 99% are already they receive antenatal care during pregnancy. Also, we encourage pregnant women to have institutional delivery, and we succeed also to maintain that more than 99% of them they have either hospital deliveries or in health facility primary health care deliveries with delivery facilities. The remaining they deliver on the way, but they got admitted also in the postnatal ward. By this we were able to capture all deliveries and also newborn. And we are keeping the mother for 24 hours in the postnatal ward where the birth dose are given. So the birth dose are given to the newborn before the discharge. So that is why we succeed also in achieving the high coverage of the birth dose, because MCH and EBI working together at hospital level. The other key element is the linking between the hospital where the delivery took place and the parent institution where the mother and the child will follow up, because after delivery, the hospital or the place where delivery took place, they should notify the parent institution where initially the woman registered for her pregnancy, and to facilitate later on following up the child for immunization. At primary health care, for the providing a child care, we are providing it is as a package. Like we have a routine schedule, a child health visit, and this visit tailor with the timing of immunization. So the child receive a package of service including assessment, growth assessment, assessment of nutrition, developmental assessment, as well as immunization in the same room. So for example, the EBI staff nurse, she's the same one who are doing screening for autism. So the role of MCH in summary was in increasing the coverage, because we increase the coverage we work together in collaboration with the other programs, EBI, HIV, and hepatitis in planning and implementation. We implement the program as integrated service, not as a vertical service. Also, we succeed in increasing the coverage of ANC coverage as well as delivery. So we will capture all mothers during pregnancy, which facilitate later on delivering the birth dose of immunization. We provide the child health care as a package of service integrated at primary health care, and we have a system of follow-up of defaulter. So this is in the summary on the role of MCH. Thank you. Over.
Dr. Jamal, you are muted if you are speaking.
Thank you, Dr. Jamila. I want to ask you if you have any challenges. You are one of the best countries in coverage, but was there any challenges or any lessons learned that you want to tell other countries?
Yes, like initially, like EBI program when it started early 70s, it was like when we started earlier, we started maybe as a vertical programs, but later what the lesson was learned that by integrating the service as a package, It facilitates the implementation and increasing the coverage. So that is one of the main lessons
What
which
do you
we learned.
mean by a package? What do you mean by a package?
A package, for example, similar like for the child health, if we talk about the third dose of hepatitis B. So the third dose, when we are giving it at 6 months, it's not that it is integrated with the routine visit for the child in 6 months. So the child will receive nutritional assessment, will receive developmental assessment, as well immunization. So we don't have like EBI room separate from another room for providing a child health care. So it is the same service provided at one time for the child. So we don't lose a child. Like a child, if he's coming for any purpose, we are providing the same service at the same time.
Thank you, Dr. Jamila. And now, if you have any questions to the speakers, please go on. If not, I have a question back to Dr. Dilaur in Afghanistan. I want to know also the role of the patient associations in Afghanistan concerning the hepatitis B elimination and the work on hepatitis.
Thank you once again. This is Dr. Ehsan, the senior program coordinator for HIV and AIDS and hepatitis, and I will talk instead of Dr. Dilaur. Association regarding the hepatitis, especially under the name of Association for the Hepatitis, we don't have. Just we have one HIV network. That's some of the clients also, they already have so hepatitis in the same time. So with this networking working for both for hepatitis and also for the HIV. And also one steering committee was established about 3 or 4 years before. And right now we have one technical committee. They are working on the hepatitis program, and another is a steering committee where all stakeholders are part of that committee. And special the patient association still it's not active in Afghanistan. Thank you.
Thank you very much. I think Dr. Jumana has a question. Please, Jumana.
Yes, thank you, Dr. Gamal, and thank you to the panelists for sharing those experiences. I think it's very enlightening to see this diversity of presentations with a very, very high achiever and giving us a clear lesson from a high achieving country, Dr. Jamila, on the ownership by the MCH program of the intervention and putting it in the essential package of services for the newborn and the mother. I think that's a very, very powerful recommendation we can take from this panel. So I would like to ask maybe Dr. Ihsanullah and Dr. Sofia on how much of this can be used in your country to scale up hepatitis B birth dose and third dose vaccination. I know in Afghanistan in 2019, birth dose vaccination coverage was only 37%, and in Pakistan around 50%. So how can this lesson we heard from Dr. Jamila apply in your country, and how can we use the existing systems in your countries to scale up rapidly birth dose and third dose coverage? So back to you.
Dr. Jumana, I'm once again, Dr. Isan, and thank you. That's you mentioned some of the points, especially for the birth dose. One thing, that's how we can to scaling up the activity is for the prevention and treatment, or the elimination, especially for the hepatitis and in Afghanistan. And the very big or very urgent things, that's one, we don't have a budget and source of the budget. How we can to manage these two things, and also for the research, and also to know the prevalence, and also to the gap. It needs some assistance, but unfortunately, such assessment still didn't conduct. And also we are in the process, that's how we can to advocate to attract the attentions of the all the UN and globally to care for this particular issue. And last week I was in Islamabad, and when I was discussed, and the hepatitis is more in the refugees. But in the refugees, we don't have any research on other things. And also when we collecting the information from the private sector, even, and from the hospitals, so we do know the exact number of prevalence. It needs to have a more research and a big research, that's to know that's the amounts or the of the hepatitis C in which population, and especially in the KP or general, it is more. Then we should go to the scaling up and according to the strategy was developed. That's how we can to go for the elimination and scaling up of the services. And so right now, and the big challenge we are faced, that's the budget. We are in the communications with the governments. Still, we didn't success to have approval of this budget. And also, as before, also I mentioned, we are in the advocates with other donors that even we developed a proposal for the United, but still we didn't success. But just from the technical aspects, and for example, the developments of the guidelines, protocols, and also SOPs, and also for the strategy, we have all these things. And thanks from the WHO colleagues, they always support us. But right now, the big support is the financials and the support for us. Thank you.
Thank you, Dr. Hassan. And there is a question from Sudan, Dr. Sarah to Dr. Jamila.
Okay, thank you, Dr. Jamal again. Yeah, I already wrote it in the chat, but I am just asking how Dr. Jamila, how do you exactly link the positive mothers during the antenatal care for you mentioned that it's a package. So do you include the package of prevention of mother-to-child transmission? Do you exactly give positive mothers the treatment in the second trimester, and then you give the bear's dose and immunoglobulin, and then you follow? How do you do this pathway until you get the babies free from the hepatitis? So just I need to understand, this pathway.
Yes, if women, she's already known positive. We, of course, depending on the viral loss, there's a follow-up during her pregnancy, and we are linking with the physician, or with the hepatologist, okay? And she will have a follow-up during antenatal. And after delivery, if the baby needs, he will receive also immunoglobulin in the postnatal ward. So for positive women, we are linking, we have guidelines for referral, not only for hepatitis, for HIV and any chronic disease. We have guidelines for those who are having a positive during pregnancy, where to link and where to refer. So that is already included in the national guideline. Until now, we didn't implement. There is opportunistic screening for hepatitis B during pregnancy in some facilities, but we have discussion already, start by the section of hepatitis, to going for national screening during pregnancy. And of course, there will be a system for referral from primary to secondary and to how to follow up this one. But currently the positive women are linked for treatment also.
Okay, so
I hope I answered your question.
Yeah. And then you test the babies when exactly the babies of the positive mother to ensure that they are free from hepatitis and they did not got the infection after all these interventions.
So these the children with like in addition, like as I mentioned, depend on the viral load, and usually we had a study, recent study, which was done in a pregnant woman, and we found that the prevalence, it's already published recently, we found the prevalence it's 1.5% in pregnant women. The sample was 2,200. And the majority of these positive women, they have a very low viral load. So the majority, which we, for pregnant women, which were discovered they have hepatitis B, are very low viral load, which means the chance of the transmission is low. And even postnatal, as I mentioned, during antenatal, there's a close follow-up of this woman, and after delivery for the baby, because majority of deliveries took place in the hospital level, so there's pediatrician for follow-up of these children.
Okay, thank you.
Thank you, Dr. Jamila.
Welcome.
Now, I want to thank the speakers, and if there are any questions from the participants.
Yes, Dr. Gamal, there's a question on the platform.
Yes.
From Shaima. The question is to Dr. Jamila, asking whether you have noted any disadvantage of integration, whether, for example, because of integration, you lost any benefit of the program or any service. Can you talk a little bit about this?
To be honest, we didn't notice any disadvantage of integration. It is the opposite, because if you are not integrated, it will be most costly. It will be more difficult. Imagine like the child is coming one time for immunization. The next day he will coming for just a routine checkup for child development. We found it is most cost effective and more the system is more user friendly for the client. And as you mentioned also, like it facilitates even at birth, because if you are not integrated, the EPI, the postnatal ward, it will be difficult later on to catch up after discharging the mother and the newborn to give the birth dose. It will be difficult for the EPI to follow these children. So to be honest, I didn't find any disadvantage. It is the opposite, because when we start the program, the EBI started in early 70s as initial as vertical program, and there are some service for child. The coverage was not, of course, not for hepatitis, but for other immunization. The coverage was not to that high, but when integrated in the 80s with the MCH package, all coverage increased.
Thank you, Dr. Jamila, and I want to thank you all for this information. But I have a question to all the speakers about the antenatal care. I mean, screening for pregnant mothers. Is this practiced in Sudan, Dr. Sarah? Do you do screening for pregnant mothers? Because
actually, it is there since a long time, by the way. And the private sector is holding a huge number of pregnant ladies, because the health-seeking behavior of pregnant mother there is to look after their pregnancies in the private sector rather than the public ones. So I think we are missing a lot of huge data there in the private sector to catch how many exactly, because the program at the Mother and Child Health is only capturing 30% of those women. So we have also the women at the community level, because we have deliveries, a huge number also is happening in at the community. But at the private and even the public, they are doing the screening for B and C and the HIV. But unfortunately, it's not captured by the information system. So this way, where we are prioritizing to capture those data in order to make use of this.
Thank you. And Dr. Ibtisam, what is the situation in Morocco?
I think she's no longer here.
Dr. Dilawar of Afghanistan. Dr. Jamila, what's the situation in Oman?
In Oman, we have opportunistic screening. Like until now, we don't have a national, the screening for hepatitis during pregnancy is not as a part of the national program, but some facility they are doing. But currently, we have discussion, like we had meetings between us and the department looking after HIV and hepatitis, and we are planning to put a plan to include it as a part of the national package of screening during pregnancy, along with the HIV screening. So there is a plan.
Very good, very good. And with this with this information coming from these different countries and all these experiences, we hope that our goal towards hepatitis B elimination will be on the road, and we can reach it in most of the countries. Finally, before I close, any closing remark from Jumana?
Yes, I want to join you, thank Dr. Gamal, first by thanking you for helping us moderate this session, and also for bringing elevating the agenda of patient involvement and patient association involvement. So thank you for always asking about that and keeping us reminded that this is an important part of the response, and essential also to make sure that we go in the right direction. I want to thank all our speakers, the presenters and the panelists for sharing their experiences. I hope that by this mix of interventions that we had in this session, we could give some light on some key challenges or key areas that countries can use, learning from each other, they can use to help scale up quickly. I want to specifically shed light on the Oman experience, and this integration and collaboration between the programs is crucial for any success of birth dose vaccination and third dose vaccination. I think without this collaboration, the vaccination program will remain without a father, and nobody will own it if it is not in the essential package of services of the newborn. And everybody contributes from the hepatitis program perspective and from the immunization perspective. So Oman is a great achiever, not only in hepatitis B coverage, but hepatitis B vaccination coverage, but also soon, hopefully, we will celebrate the validation of elimination of mother-to-child transmission of HIV and syphilis in Oman. And that's the first country in the region. And hopefully we will build on that and validate also elimination of mother-to-child transmission of hepatitis B soon. So I thank you all for this and for sharing your experiences and being open about your challenges. and the discussions we had. Thank you very much. And back to you, Dr. Gamal, for the final words.
Thank you, Dr. Jumana. And with the final words from Dr. Jumana, I thank you all again and hope that we will learn the lessons from this important discussion. Thank you. And with this, we close the session. Thank you all.
Thank you. Bye-bye.
Thank you. Thank you, everyone.
Thank you.
Thank you.